between the groups, and in the control group and the group of knockouts of TKS4. We have a lot of cells invading, and a few cells invading is statistically significant, have statistical significance. But Ameloblastoma form invadopodia. To check invadopodia formation, you use an invadopodia assay. Look, we put on the fluorescent substrate the cell, that is some unpaired cells, a cell line from Ameloblastoma. It's a fluorescent substrate with gelatin, with orthogonality 48 fluorochrome, and above on the cover slip. Look, when the cell leaves the fluorescent substrates, we form an invadopodia, and we can see the invadopodia formation by the dark dots or areas in the gelatin fluorescent, in the fluorescent substrate. Look this video.
Just a minute.
Look at this video. In red, we can see the gelatin with fluorochrome in red. In green, the cell line. Just a moment, please. Come here, please.
Ok, acho que se você clicar aqui do lado esquerdo.
Quando mudei para quantas vezes ele saiu da apresentação.
Sorry, guys. Just technical issues.
It's okay, Prof. I can see the slide.
Just the video is not running.
It's running before, but.
Yeah. If you don't mind, you're going to run the videos in this mode. It's going to be easier. Then we return to presentation mode, right?
Yeah, of course.
Okay. Fluorescent substrate in red, the gelatin in red, and in green, the cells. Look at the position of the cells. And now, in this movie, look dark areas in the gelatin. This is the degradation of gelatin. This is the formation of invadopodia for lysis of gelatin. Look again. Okay. We make a invadopodia site for observe the degradation of gelatin by Ameloblastoma cell line. Look this image. In A, we have the cell. So in red, you have a phalloidin labeling. In B, the gelatin, nucleus of cells in blue, in red, phalloidin. In C, you can see the dark area, the degradation area. This is in control. Cells without RNA, cells without knockout for TKS4. And here, picture D, A, and F, we can see in cell line with a knockout for TKS4, we can't observe the degradation of gelatin. You observe this degradation of gelatin. And the graph, the statistics confirm that in control, without the cells, without knockout of TKS4, we have a more percentage of degradation with a statistic difference. Look, we have expression of MNPs in ameloblastoma. We have expression of growth factors in ameloblastoma. We have the expression of proteins key of formation and activation of invadopodia. And an important role of TKS4 in this process. Another question, some papers have showed the important role of hypoxia in tumor formation and invasion. Hypoxia is a low oxygen concentration in a tissue and favor the formation and activation of invadopodia. The low oxygen concentration favor the formation and activation or activity of invadopodia. Is associated with cell invasion and potentiation of formation of invadopodia and metastasis. The picture of histological aspect of ameloblastoma. Look again, the island of epithelial cells. This island growth and this island don't have nutrition, proper nutrition. And in some time, these central cells have a lower quantity of oxygen, characterizing the hypoxia condition. Diaz and collaborators showed the interactions between proteins and hypoxia. Look this picture. Here we have a protein membrane protein, JAGD2, and NOTCH1. JAGD2 activates NOTCH1, binds and activates NOTCH1, and remove the expression of gamma secretases, then they cut the NOTCH1 and release the intracellular NOTCH1, and this NOTCH1 is transcribed to the nucleus like a hyphen alpha. Look, this is in hypoxia condition. When NOTCH1 intracytoplasmatic and hyphen alpha go to the nucleus, by transcription, we have a signalize for more expression of ADAM12. ADAM12 is an enzyme or family of the MMPs, then cuts the pro-HBEGF and release HBEGF. HBEGF, a growth factor, can bind in EGFR and remove the formation of invadopodia in hypoxia condition and normoxia condition, in paracrine 4 or autocrine 4. In another paper, we can show the expression of this protein, NOTCH1, hyphen alpha, ADAM11, and HBEGF. By immunohistochemistry, we can show the expression of NOTCH1. Look, this brown stain is the expression of NOTCH1. Look, the higher expression of NOTCH1 in parenchyma of tumor than in the stroma of the tumor. You can see this again here. Look at the expression of hyphen alpha, sometimes in the nucleus of the cells of ameloblastoma, of parenchyma of ameloblastoma, and sometimes in both nucleus and cytoplasm. Look, sometimes we observed the expression in nucleus and cytoplasm of the neoplastic cells near of microcysts of ameloblastoma. It's interesting. We can show it in another paper published in Clinical Investigation that hyphen alpha stay near of the cavity of a lot of cysts or a lot of odontogenic cysts. Possibly this expression, the hypoxia is the cause of the formation of the cystic cavity. This is a expression of ADAM12 in the parenchyma of neoplastic cells of ameloblastoma. Here, the graphic shows the higher expression of these proteins than the control with CCOT and dental follicle. We have a higher expression of the NOTCH1, hyphen alpha, ADAM12, in the BGF in ameloblastoma. And the higher expression in neoplastic cells, we've compared with stroma. And another question, is invadopodia formation is influenced by hypoxia? For this, we make a mechanistic study. Ramos is analyzed the immunoexpression of proteins in ameloblastoma cell lines by immunofluorescence. And here, scanned for this study, we've used a double staining or labeling, and not were labeling in red, hyphen alpha in green, Adam 12 in red, and HF in green. Here, this picture, we can see the expression of hyphen alpha in green, Notsky 1 in red, in hypoxia condition and normoxia condition. Look, you have a higher expression of hyphen alpha and Notsky 1 in hypoxia condition than in normoxia condition. The graph shows the fluorescence intensity. We quantify the fluorescence intensity. It's not in hypoxia and normoxia, and hyphen alpha and hypoxia and normoxia. We have a difference, a statistical difference, only in the level of the hypoxia, in the level of the hyphen alpha. Of course, we have a height expression of hyphen alpha. Hyphen alpha is only expressed in hypoxia conditions. It's clear, it's obvious. You have a more expression hyphen alpha in hypoxia condition in ameloblastoma saline. And here we have the expression Adam 12 and HBGF. In green, HBGF, and in red, the Adam 12. We can see two higher expression of HBGF and Adam 12 in hypoxia conditions. The graph showed the more intensity of fluorescence Adam 12, of Adam 12, and of HBGF in hypoxia condition when we compare with a normoxia condition. Look, we have a higher expression in cell lines in hypoxia of Adam 12 and HBGF. This pathway is possible in ameloblastoma, works in ameloblastoma, and possibly make a lot of high quantity of invadopodia. Another question, what's the role of NOTCH1 in invadopodia formation in hypoxia? For this, we knock out the gene of NOTCH1. Look, the first picture. We confirm the knockout of the partial knockout of NOTCH1 in Untitled cell line or from ameloblastoma. Look at the size of bundles is low, not the low expression of NOTCH1 than the control. Confirm the knockouts. And after the knockout of NOTCH1, we make a invadopodia in the cell line. Look at in A, we have a normoxia condition, and in B, we have hypoxia condition. Look, we have dark areas in gelatin of control and a few areas of degradation in cells with Notch1 knockouts. In hypoxia condition, we have we don't have a degradation of gelatin. On the other hand, Notch1 have an important role in invadopodia formation in hypoxia condition. Look, only in hypoxia condition in cells that don't have knockout for Notch1, we have a degradation of high area of gelatin. When we have knockouts, we don't have a large areas of degradation of gelatin. The hypoxia probably active the whole of Notch1. We can make some conclusions. Possibly, several proteins can mediate local invasiveness of ameloblastoma, such as MMPs and growth factors. The formation of invadopodia seems to be important for this invasiveness and local recurrence to occur. Hypoxia appears to intensify the formation of invadopodia in ameloblastoma cell line. Taken together, those results strongly suggest that several biological mechanisms act to favor the ameloblastoma aggressiveness clinical behavior. This is a sunrise in my city, Belém, Pará, in the north of Brazil.
Wow.
This is a sunset. This picture from my house, you can see here the Amazon River. The Amazon River passes in front of Belém, in front of my city. In close, you can see the Amazon River and the rainforest, the Amazon forest. And here, Annie, you remember, this is Thames River. Yeah. Thanks for your attention. Thank you for inviting me for this. It's a pleasure for me to stay here in the evening with us, with yours.
Okay.
Thank you.
Thank you so much, Prof. Joao. It's a very interesting discussion, presentations. It's a huge new information about the pathomechanism of this invasiveness of this ameloblastoma. Prof. Joao, if you don't mind, I will delay the Q&A for you, and we'll go to treatment of this odontogenic tumor by Andre. Dr. Andre?
Hey.
Hey, are you there?
Yes.
Okay.
Just
Okay. I will continue your presentation, and then we open the Q&A session from both of you. For the brief introduction, Dr. Andre, the handsome Dr. Andre here. Are you still single, Andre?
No, I got like 4 or 5
Oh,
kilos.
dear. Is it including
but
me?
it's due to COVID pandemic. It's not my fault.
Okay, so Dr. Andre Luis Ribeiro Didiis, and Master Science PhD, graduated at Odontologia from University Federal de Bahia in 2002. He got his master at odontology from University Federal de Para and doctor at University College London. So he was actually my senior at my PhD program, and he was, although he is an oral surgeon, he was excellent in immunology. Believe me, I don't know which one is best, your expertise in oral surgery or in immunology. Uh, his professional, he was joined with the Institut de Chirurgia Oral e Maxillofacial at the Bucco-Maxillofacial Chirurgia. I think it's a surgery, yeah, Andre?
Yeah, that's oral and maxillofacial surgery.
Oral and maxillofacial surgery at the Belém, Brazil. And then he also a referee for some journal in dentistry, like Journal of Oral and Maxillofacial Surgery, Journal Pathology, Research and Practice, Journal of Injury and Violence Research, and some other journal. He has 50, more than 50 publication. I couldn't mention it in here. And what else? Yeah, so he has a lot of publication regarding the surgery. What is your main interest, Andre?
It's quite complicated. It has changed a lot from time. I think because my history, like after my graduation, I go straight to my residence program, and at this time my main passion was trauma. So I worked a lot with trauma patients, and at this time I was teaching as well. In 2013, there was something happened. I wasn't really happy in my life because it was very stressing, and I decided to do the PhD. And one thing for another stressing thing, but it was nice. So when I came back, so I changed a little bit my practice. So I started my private practice basically 1 year ago. So now during this time, it has changed a little bit my interest. Now I'm focused on orthogonality surgery, implant dentistry, and yeah, some kind of cosmetic procedures. So before I was working a lot with odontogenic tumors, trauma. Now I'm changing a little bit my focus. So it's always changing. But we should put us always like looking for some challenge. For instance, he's challenging himself for more than 30 years studying odontogenic tumors.
Okay.
With a lot of contribution in this field.
Okay. Please, you can share your screen, Andrew, and I give time for you to present. It's a good idea that you go for your PhD to forget your happy life in Brazil.
It was like it was a good learning.
Yeah, it's a good learning.
We learned a lot. It was a new thing that I was doing in my life, and also a very good life experience.
Yes, agree.
And yeah, it was very important.
Okay.
And okay, good evening, everybody. I'm really, really glad to be here talking to you. I would like to thank the provost of Hassanuddin University, the dean of the Faculty of Dentistry, and especially Airway for this kind invitation. We met during our PhD in London, so we had like a lot of time to study. What's really, really important, for me as a personal experience, I met like people from different culture. I don't know how it is for you in Indonesia, but Brazil is a great country, really, really great. And because our location is difficult to live with different cultures. Basically, it's very rare where we are now, like in Belém, to meet foreigners. And in London, I could meet a lot of people, so different cultures. Amy was one of these picture. And here you can see an image, like we had like time for hard work, but a lot of learning, but we enjoyed a lot. We had like friends, and this picture, I was at this time, I was doing some experiments with human cells, and I need blood for many people. So almost everyone in the lab had to give blood, including us. So we can say that during this PhD, we gave our blood during this time. So thank you, the Hassan University, and thank you everybody for listening to this presentation, right? So Dr. João has worked like with odontogenic tumors for more than 30 years. And what he showed to you is like why some like lesions have like a different behavior. Why, for instance, Amoloblastoma is so aggressive. So it's because it's the nature of their cells, which has like a biological mechanism to invade tissues. So I'm gonna challenge, not challenge a little bit, but I'm gonna put not what we can see in papers, but I'm gonna try to show you my personal experience and what are my feelings when I'm treating these patients. And yeah, by doing this, I'm gonna put myself in the line of fire. So I think this is an opportunity to I'm not showing anything new to you, but I'm just questioning something that we can see in papers, and I'm gonna place my personal experience. And yeah, I hope we're gonna have a great opportunity to discuss this. I really like, I think this discussion is the best thing we can do here. And I don't mind if you criticize me because what I'm gonna say or why I'm treating these patients, but yeah, we need to question ourselves all the time. So just to you understand where we are, so we are in Belém, Brazil. Brazil is divided in 5 regions. We are in the North region. Most of this region is like taken for the Amazon rainforest. So as João said, we are here, you can see on the pictures, we are like surrounded by the Amazon River. We are almost opposite in the globe, like 11 hours difference. So basically we need to cross the whole globe to be in Indonesia, or if you wanna come to Brazil. Yeah, so that's the series. There are some characteristics of this region that I'm going to explain a little bit later, but this is the poorest region of Brazil, less developed. Everything is like all the statistics in this region in terms of quality of life is lower than any other regions in Brazil. So it's going to create some challenges for us surgeons when treating this patient, because we don't have access some type of technologies, also some profession that could help us to do, for instance, a specific procedure or a specific surgery to reconstruct this patient. So to place you in terms of like context, so my talk is about the surgical management of aggressive odontogenic tumors. Basically, I'm going to use Ameloblastoma that João was talking a lot before, because it's the most significant, and it's very aggressive. And yeah, it's a good example of an aggressive odontogenic tumors. And when you talk about like aggressive lesions, the ideal treatment is remove all neoplastic cells, right? So if you were able to remove all the neoplastic cells, you could say that this patient is free of this disease, but it's not always easy. Okay, and I'm gonna show you. João showed you before that why ameloblastoma is so invasive and it recurs, and for instance, after a resection surgery occurring in, for instance, in bone graft. So it's really, really aggressive. And to put you in this context, it is important to understand that the practice of oral and maxillofacial surgery is different in almost every country. I don't know how it is in Indonesia, but you can see, for instance, in Brazil, it is like a dental specialty. In some European countries like Portugal, I think France, it's a medical specialty. In countries like UK, you require dual graduation in dentistry and medicine. In the United States, they have like a different degree, like after, if you do a long, like a residence program, I think it's 6 years long, you got like a DMD, is a different category. It is between dentistry, it is still a dental specialty, but it's between dentist and medicine. So it varies a lot. But the reality in Brazil, as our maxillofacial surgeons, we don't treat cancer, right? The board here, we are not allowed to treat cancer, and it's most like head and neck cancer are treated by head and neck surgeons. So because our regulation, we cannot operate below the hyoid bone, and for instance, these malignancies, you need to explore the lymph node, the cervical lymph nodes is the most common metastasis area in the head and neck cancer. And because also we cannot like working outside of the head and neck, we don't have like training in microvascular surgery. So if I need like reconstruct a bone, I need the help of like another surgeon that is trained in this field, which is not very easy to find in northern Brazil, in Belém. Most people and most surgeons, because they are not interested in helping during this procedure. It's demanding. It's a very skilled like a procedure. There are a few surgeons, and mostly because most patients who needs this type of reconstruction, they are in the public service, so that doesn't pay a lot in Brazil, and it like makes the interest of surgeons. They are not that interested in this area. So we got a dilemma. I'm as a surgeon, got a dilemma in my hands. Whenever I see an aggressive tumor, if I want to remove this tumor, remove all the neoplastic cells, I probably, as João said, I need to do an aggressive surgery. And I'm going to end up with a patient with a huge bone defect that I don't know, I don't have ways of reconstructing it. So João has showed this picture before, and this picture is one of his work. He's made like a lot of contribution to the understanding of like aggressive behavior or invasiveness of odontogenic tumors. And I'm stealing his image. For instance, João is a very important person to me. He was my supervisor during my master's. We have published more than, I think, I'm guessing here, but more than 30 papers together. And yeah, this is an important thing. When he showed that, you can see here that tumors, if you think about non-aggressive or cystic lesion, they usually grow to hydrostatic pressure. So inside the lesion, like a cystic lesion or non-aggressive tumor, the central cells probably get in hypoxia, and these cells, they die and expose their contact which has hydrostatic pressure, so it attracts water inside this lesion. And by attracting water, if you create pressure inside the bone, and this pressure in the bone causes the resorption. So most cysts and non-aggressive lesions, they grow or for hydrostatic pressure, or even for growing the number of cells and make pressure in the bone. But when talk about these aggressive tumors like ameloblastoma, these neoplastic cells, they have other means to grow. They secrete these proteins that João was showing to you, and it causes local resorption of bone. As you can see here, it's with this projection, which is called invadopodia. So then comes a surgeon that when I treat this lesion, what we do, we try to remove the tumor, and basically we remove whatever we are seeing. So all these projections that are inside the bone are kept in place. It happens when we do conservative surgery. So by keeping these cells inside the bone, this we cannot see. This is microscopic, and we cannot see this during surgery. So these cells remain imprisoned there, and over time, probably they will cause recurrence. That's why conservative surgery usually results in higher recurrence rates. Right? So then we need to think what's the right treatment for these aggressive tumors like ameloblastoma. Then should we do radical surgery or conservative surgery? When we compare these the results of these procedures, we can see that when we do radical surgery, we have a lower recurrence rate because we usually use a safety margins to remove the tumor. So we don't direct manipulate the tumor. We use this safety. It's an area of normal tissue to remove the tumor. But it creates higher morbidity. And so the ideal treatment will require complex reconstruction. By doing conservative surgery, we increase a lot the recurrence rate. So it's 3 times higher than using radical surgery, but it results in less morbidity and less complex reconstruction. Okay, and I think it's a different version, but so we need to question ourselves, what's the right treatment? So when you go to the literature, it says the right treatment is radical surgery, because basically the papers, they based their conclusions on the recurrence rates. So which one gives the lowest recurrence rate is the recommended treatment. But to do this, you need to do a radical surgery, and we're going to talk a bit about it. So this is a question that I keep doing to myself. Who are we treating? Are we treating an ameloblastoma, a tumor, or are we treating the patient? Why am I doing this question? Because I have difficult to reconstruct this patient. As I said before, as a maxillofacial surgeon in Brazil, we don't have training in microvascular surgery. Free bone graft usually it causes there's a lot of resorption, infection, and whenever I try to do this in large defects, I end up I lost this graft most of the time. And it's very sad to see a mutilated patient that cannot eat, cannot talk properly. And because after the treatment, he got a huge defect in his mandible, which is the most common bone that ameloblastoma or these aggressive tumors appear. So that's something that I want to keep in your mind. Who are we treating? Tumor? So we should treat all ameloblastoma in the same way, or can we adapt it to the patient that we are seeing and the condition? For me, my current condition, I don't have a microvascular surgeon with me. So if I resect it, I can in the maximum put a reconstruction plate and leave the patient like this. So talking about radical surgery, it basically means that we need to include a safety area, a safety surgical margin. So we should remove part of normal tissue from wherever is seen in the tumor. This surgical margins, literature says it's 0.5 to 2 centimeters. And others, they say that we should base the treatment on the histological type, unicystic or peripheral have a lower recurrence rate. It can be treated in a more conservative ways. The solid type requires aggressive treatment or based on imaging, or others you should base the treatment in frozen biopsy during the surgery. So if you do radical surgery, we're gonna do this. I changed it. Sorry guys, I changed a little bit this picture. The quality is not very good. I replaced this one, but I think I opened the wrong presentation. Sorry. But here, let's say, if we're gonna define some margins for this lesion, we can see here. First, we can see that an interesting thing. We can see that the margins of this lesion is not a regular one. So if you look here, you can see that there are areas that the tumor seems to invade more than others, which is this local invasion. If you are looking to a cystic or non-aggressive, it's probably would be a well-defined margin, right? So if I'm looking to this tumor here, I'm going to include a safety margin. So we remember the safety margin is not only in medial or distal aspect, it's all aspects. So here, I don't have enough bone. It's just probably 1 or 2 millimeters thick. So if I need at least use the lowest 1.5, I cannot still leave this bone here. So I need to do a segmental resection. That's going to leave a big bone defect. And it's not my case. I got this one from literature. The authors, they are from Australia and United States. So I have never seen a case like this. So it's a very aggressive ameloblastoma. But that's the main difference that developed countries they have. They have all the resources and all the trained people maybe to give like the ideal treatment. And because most papers are come from like developed countries, because they have much more money to invest in research. So they base the conclusions and recommend treatment based on whatever they have in hands. That's not my reality. You can see a big tumor like this. The author did like a huge resection in the mandible. You can see here, really, really huge. But they can do microvascular surgery, dental implants, and after treatment, this patient is able to, they were able to give the patient aesthetic function bone. So probably after this patient wasn't like with dental prosthesis yet, but after like placing the prosthesis, the patient can chill, can return to almost to a normal life. Then like can do almost all the things that people, someone that didn't have a similar lesion could have. But yeah, the sad reality that we have here, I told you that's a poor region in Brazil. The most patients, the characteristic of my patients, they come from the public service. Usually the diagnosis is made late because they took a long of time to come to us because of the bureaucracy and a lot of things. They have low income, low educational level, poor oral hygiene. So it's poor people. And because that the difficulties that we face, we don't have like anyone to help us with microvascular surgery. What remains is like in these cases, we need to do radical surgery. And you can see here a huge mass, tumoral mass in the left side of this lady. It was like take almost half of her mouth. She was like chewing over the tumor. So it's a really, really huge lesion. So basically taking the TMJ. In this case, treatment was radical surgery. I removed the half of the mandible. And here is the tumor. What I can do in terms of reconstruction, just put in a titanium plate that will give some contour in the mandible, but functionally, it's not good. Here's the patient after surgery. We still can see some asymmetry. When she opens the mouth, like the movement is very, very strange. It it's deviate a lot. The patient cannot use like a dental prosthesis, so she cannot chew properly. So it's very mutilating. Here's another case. Yes, another huge tumor. We can see is an old lady with a tumoral mass in the right side of her mandible. It was like causing her pain because you can see some ulceration in the oral mucosa. The X-ray show a multilocular radiolucid area, so a huge tumor. So basically, I planned as radical surgery with like a bone resection. This procedure, the same thing, removing the tumor. We can see I was able to leave some bone on this side, placing a reconstruction plate, and here the patient a few months after treatment. Yeah, probably she's a little bit better than she was before, but she now is free of tumor, but got like functional problems. And because that, I was reflecting about what can I do better to these patients? Is there any way that I can change a little bit my technique to improve the patient's quality of life? So if you perform what the treatment like recommended by literature, which is radical surgery, we're gonna end up with huge bone defects and low quality of life. And this is something that I was thinking that, in my view, scientific papers must include evaluation of quality of life of these patients before and after surgery. Sometimes I question, I have asked them, oh, how do you feel after treatment, after radical surgery? And they say, you know, I cannot chew, my mouth like deviate, I cannot like bite anymore. And I think this, the opinion of papers, of patients should be included in terms of questionnaire, and to help us, to help surgeons to take a better decision. And it's also my opinion. That's why I'm gonna put myself in the line of fire. You can challenge me, but I think treatment plans must be based on patient, not only the lesion. Okay, so it's a ameloblastoma, it's a solid one, so let's do like a radical surgery and keep patient mutilated. I don't like this. So I'm going to show you this patient. It's late, I think at this time she was around 27, 28 years old, and she got swelling in her left side of the mandible. So it was asymptomatic with most of this lesion. Patients usually complain of pain or something else after this tumor. They got like a big size, and you can see here that it was just taking like a huge part of her mandible. Unfortunately, the picture is not here, but what I'm using as an alternative treatment, I'm performing masculinization. I don't know if all of you know what it is. Masculinization is a surgical technique where we open, like we expose the usually a cystic lesion, or in this case a multicystic lesion, to some cavity. So by doing this, we remove the interlesional pressure. So this is hydrostatic pressure. We remove this, and also expose these neoplastic cells to many irritants that are in the oral cavity or nasal cavity, wherever, usually the oral cavity. So in this case, we remove part of the lesion and leave this lesion open with something inside. I usually use like a gauze soaked with antiseptic solution, like iodine solution, and the patient changes this dressing every day. And the first days the patient come to me, I do this change of dressing, and after I teach them, so over time they become able to change like dressing at home, and they remain doing this for a few months. And this is masculinization. When you open some like a cystic lesion, it leaves this exposed to the oral cavity. As I said, by doing this, we remove the hydrostatic pressure. You also, by exposing the neoplastic cells to an hostile environment, it changes the biology of this neoplastic cell. It causes metaplasia. So everything that Joan was telling you, the biological mechanism that neoplastic cells use to invade tumors are like they change a little bit, and usually these cells, they become less aggressive. So we got two things here. We transform the neoplastic cell, they pass through metaplasia, so it became less aggressive. And also we remove the hydrostatic pressure. The result of this is what we can see here. We can see that before the patient can see barely like a thin layer of like the basal bone of the core and of the body and angle of the mandible. And after 6 months of masculinization, you can see how much bone was formed after this procedure. And I keep like following up this patient, and in my experience, after some time, we stopped to have like bone formation, and the lesion also stopped to shrink. And when it occurs, I go to a second stage, a secondary surgery, to remove the the tumor with a more conservative surgery. So after masculinization, now here, this is masculinization. So we open a space, exposing the neoplastic lesion usually to the oral cavity. Okay, so after the lesion has shrunk, I go there and do like I remove all the remaining tissue using enucleation. Enucleation is a more conservative that we don't remove this, we don't have these safety margins. So I can do an intraoral approach. I don't need like do a skin incision. So I perform enucleation, and then I do peripheral ostectomy. As you can see, it's not here, it's changed a lot, but I usually take a straight hand piece with like a maxi cut, like a burr that you use to dental prosthesis, and go there and remove 1 or 2 millimeters of like a bone inside the lesion. It's called peripheral ostectomy. So first stage, masculinization, and leave there until the lesion stops to shrink and there is enough bone formed. It usually takes between 5 to 6 months. And then I do a secondary surgery, perform enucleation with peripheral ostectomy. And here's the patient, 6 years of follow-up. So you can see there is still like a small swelling here. I offer the patient if she wanna do some kind of osteoplasty here just to improve a little bit the aesthetic, and said, no, I'm completely fine with this. And here is the image of this bone 6 years after this treatment. So intraoral view. So the patient was able, at this time, she moved to another like city, and she did like orthodontic treatment. This was the documentation before. And here you can see a CT scan, and you can look to the bone. It doesn't look like normal bone. It's a little bit strange. But what we cannot see here is tumor anymore. There is like so far, after this tomography, the CT scan was take 8 years after follow-up. If you look here, we can see there is a small defect here, but if we follow the cuts here, you can see that this defect is our alveolar inferior nerve. So for me, it's not like kind of recurrence. It's just the nerve. It's a small defect, but look, this patient has the mandible, has no scar on the face. She's able to chill, to do whatever treatment. If she wanna place dental implants, I would say, go there, put your implants, do rehabilitation. Oh, okay, 8 years follow-up is not that long enough. Recurrence can happen like 10, 20 years after, but what's gonna happen if it's what will happen if it recurs? Malignant transformation of ameloblastoma is quite rare, metastasis as well. So it's probably recur as another ameloblastoma. we can do what we can do there. We can, if recurrence occurs, we can evaluate the lesion. If we can do another like conservative surgery or even like segmental, keeping the base of the manual, it's going to be better. The patient is like is doing everything for these 8 years while she's still young. She has a lot of things. I keep question myself, how would it be she if I had like done a huge resection, placed a reconstruction plate there? Would she be better? I don't think so. And I'm going to show you, I have like a series of patients like this. I'm not showing all the cases, but here's another situation performing the same treatment. And he, after a few years later, I had to remove this tooth. And here, before I said, I showed you a case where like with a similar patient that I did a radical surgery. And here you can see another patient with a huge tumor. So it crosses the midline and comes from the almost the 38 to the 45. If I would perform radical surgery, I would take bone probably in this region here. I'm gonna cut the bone here, cut the bone here. All the anterior region, you're gonna end up with a huge defect. And yeah, I would think, oh, is the patient better or not? So what I did here, you can see this is like a masculization. The patient during masculization, I did the same. The lesion here looked like a at least multicystic one. You can see a lot of cavities here, a lot of different cavities here, probably. So I explored this lesion, did the masculization, they removed the tooth, and here's the lesion after a few months of masculization. At this time, I did that treatment. Enucleation, so intraoral push, enucleation, and peripheral ostectomy. Here is the aspect of after like this treatment. And here is the postoperative of this patient. She looks okay. So far, no signs of recurrence. She can, if she wants, she can place like a dental prosthesis. She can, if she decides like to place dental implants or even reconstruction with bone, this area is going to be easier than if she had nothing there. So I will put these patients side by side. They have similar lesions, and I treated them in different ways. One, I did radical surgery on your right-hand side, and on the left-hand side, it was like conservative, like this. It took a little bit longer to give the patient this, so I need to do masculization for like 5-6 months. But if I ask myself which patients like to have a better quality of life, I know the answer. I would say the left one. And I always tell my patients, look, I'm going to do a conservative treatment that increases your chance of recurrence. We need to keep a longer follow-up, monitoring this tumor, but it's a little bit against what the literature says about like what's the ideal treatment. But I also do say, if I were in your place, I would choose a conservative treatment. So, as a taking home message, we have like a limited support in the literature for treating ameloblastoma conservative approach. But my personal opinion, I've got good results So far, all the cases that I treated, I only had one recurrence. It's not like probably I've got 30 patients. I have treated during my life 30 patients, and I got only one recurrence. It's some of them I don't have I don't have control of all of these cases. Many patients they disappear with time. But whenever, the good thing is like I'm still working in the same place. So whenever something happens, they come back to us. And so far, no one had turned complaining about, oh, my tumor is back. So that's why I'm keeping doing this. A good, it's an alternative technique for me. It's giving me good results. So another thing, I really believe that most studies, they should include the patient opinion, not only before, but after surgery. Because what matters for them, it's not like, they don't, usually patients, they don't even know the name of, oh, you have an ameloblastoma, or any name we can do to it. They want to be better for the problem. And sometimes when we treat them, we cause another problem. So I strongly believe that we must think about the patient, think about our local reality. I know that like in developing country, they can do a pretty good job by reconstructing jaws, giving this patient function, but it's not my reality. Here I have limitations. And based on this limitation, I adapted my treatment. Okay, thank you very much for your attention. Here you can see London during the PhD was a great time for studying, but also have time to visit place. This is a view of the Northern Lines in Iceland. And probably, I think I'm in the middle. Joan is this guy here. And thank you very much to everyone. We're gonna be here like to try at least to answer all your questions.
Yeah.
Ernie.
Yes, Andre. What a great presentation, Andre. And it's a good philosophy that the treatment must be patient-centered rather than tumor-based. It is a good philosophy. I think you are a good oral surgeon, Andre.
Thanks. I'm gonna just disappear a little bit. I'm gonna change my place to include João in the video.
Yes.
So
yeah.
Just
you can sit both in the in front of the computer. Yeah.
Just a small turn.
We have a lot of interesting question, Prof. First, I think it's for Prof. João. It say you can see it in the chat column as well, that ameloblastoma invasiveness mainly determined by the binding of growth factor and MMP. So is it possible to target one of these factors for ameloblastoma treatment? I mean, might be it's with drug to reduce the MMP or to reduce the growth factor.
Sorry, where is the question, Ernie?
You can go to the chat column. Can you see it? Is it beside the share screen?
All right, so just to check, which question are you?
It is from Abdul Aziz Ahmad. So yeah, because ameloblastoma invasiveness contributed by the growth factor and the MMP. So is it possible to target one of these factors for the ameloblastoma treatment to either inhibit the invasiveness?
Trabalhar contra a MMP ou fazer uso como alvo, se MMP ou fator de crescimento?
For treatment, not yet. But use some medical or against MMPs or growth factors, you don't have some arm for this. Don't have a medical. We have some antibodies for EGFR receptor of EGF, but it's this medicine is very the price is high, and it's not good to use in benign lesions. But in answer, we don't have some medicine for against growth factors and MMPs.
Okay. Yeah, I'm gonna say also something as well. I think I read like papers that they have drugs against MMPs. The problem is these proteins, they don't all work only in tumors. They have like a function in all the cells and all the body. The problem is when you use these drugs, side effects is huge.
Yeah, understandable.
The side effects, we still cannot target these proteins, these growth factors or MMPs yet, because the side effects. But if I can sell my place, when you do like when you do masculinization, because of this metaplasia that occurs in cell, you change a little bit the expression of these proteins. One thing that I believe that helps masculinization doing this job, because if the cells kept the same biology, I will be like unsuccessful during my treatment. Because these changes that masculinization causes, the cells become less aggressive. Sorry, I think we have done some staining in these cells before and after, and at least we haven't published it yet, but I think that is changing the expression.
Yeah, I think that about the marsupialization, we make a marsupialization, we modify the microenvironment of tumor. First, when you make a marsupialization, you remove the hydrostatic pressure, and remove the hypoxia from the tumor. You modify. We showed that the hypoxia is very important for formation of amoloblastia.
And it's locally controllable as well with marsupialization rather than the drug, which is more systematically. Thank you, Prof. The second question comes from Dr. Faisal. Thank you for the amazing presentation. Considering the aggressive behavior of ameloblastoma, what the best approach in management of ameloblastoma? Is it reasonable to perform conservative surgery or dredging? And then can we make assessment in invadopodia formation before planning the treatment for ameloblastoma?
Yeah, that's what's my main goal of this talk. Like, if you ask me, it's reasonable to perform, I would say in that way that I'm doing, I think yes, it's reasonable. I not say that the patient has this treatment is treated. We need to, because it's like an alternative approach, it's not consolidated in the literature yet. We need to have a longer follow-up. I remember it was like I think in around 2005 or 6, Antonio Progrel and collaborators, they published a paper about like masculinization in odontogenic keratosis. Remember that? And during this paper, they showed, I think, 11 or 13 cases. after 5 years, they only performed masculinization, and they showed that all patients were treated without like secondary surgery. They biopsied the areas where the tumor was previous, where the cyst or tumor changes all the time, was previously, and they said, oh, there is no pathological tissues. And a few years after, like I think 4 or 5 years after, they wrote another paper showing that some cases had recurred. And so it's a kind of like, okay, I cannot say that it was an effective treatment, but I keep question myself.
Yeah,
so
yeah, it's true.
Radical surgery and leave this bone, or what they did with this recurrence. If you can go there and then do like another surgery, treat the patient, no case became like a cancer, no case became more aggressive tumor, but the same thing, just smaller.
I understand. Yeah, so marsupialization gives you more alternative for treatment rather than the radical surgery. It's what about this? Okay, then I jump to the next question from Dr. Yeni Rahmawati. Might be for Professor Joao. Why Amoloblastoma mostly occurs in Ramos of Diamandibula? It is any specific or histopathologic reasons?
That's a good question. Maybe some students make this question, but I don't know, but in extracellular matrix of around the cells, the epithelial cells can remove conditions for the proliferation of epithelial cells and make a ameloblastoma, or originate the ameloblastoma. Interesting, a student have make a study and showed that the expression of SOX2, protein then stain cells, and we show we see the expression in dental follicle, in some cells of dental follicle, and some cells of dentigerous cyst, and a lot of cells of ameloblastoma, of parenchyma of ameloblastoma. And this protein is associated with the origin of some tumors, some malignant tumors, from the papilloma for the squamous cell, or squamous cells, or the skin squamous cells carcinoma, for example. And I don't know, but the extracellular matrix of the mandible can be different from the maxilla, and a more high rate of prevalence.
Yeah. So this question, this answer also refer from the question from Dr. Rehata Yongki, that it might be associated with the different kind of the extracellular matrix in the mandible. Yeah, Prof. So might be need more research about the different of extracellular matrix between the mandibula and the maxilla things. But we don't know for sure. Yeah, Prof. Okay, the next question from Dr. Safira Putri. Question for this amazing presentation. Is there any complication after radical treatment? of mandibular surgery, and what kind of treatment if there is a recurrency after first radical one? Andre?
All right. So if there is any complication, yes,
Yeah.
a bone defect, the morbidity of this treatment, I think is the main. There is no contraindication, but let's say if you're gonna perform, mostly you need like a skin incision, so you're gonna leave a scar. And defect, I don't know if you have seen patients like that case, this type, like have used this type of reconstruction plate. I've seen patients that use this, and because of the weight of the soft tissue and pressure, they start to pressure a specific area in the tissue, like this, and then because of hypoxia, ischemia, it goes to necrosis, and the tissue goes like a necrosate. It's like the tissue is moving, and then the plate becomes exposed. And yeah, but the main complication of radical surgery is the defect that it leaves there. And what's gonna happen if it recurs? The treatment is still the same. If you perform like a radical surgery, you still have recurrence. Ameloblastoma or any odontogenic tumor, benign odontogenic tumor, they don't have, they don't metastasize. It's very easy. It's rare, so there is no indication to perform, for instance, removal of cervical lymph nodes. What probably you can do, probably the origin of recurrence maybe some like because John showed you like a piece of bone where the cortical bone was resorbed. So the cells, they destruct the bone and they go to the soft tissue. So probably some cell could remain in the soft tissue or in the surrounding or the remaining bone. I don't know, but some cells were left there. Or what you have to do, go and remove again. That's still the same option.
Yeah, the same option. And then
by doing conservative surgery, if it happens to me, a patient that I treated in a conservative way, if it recurs, probably literature is gonna say again, do radical surgery. I wouldn't do that. I would analyze the case, see if I can still perform conservative, because you're gonna have that, it's a smaller ameloblastoma. It's gonna be easier to remove.
Yeah, the same again. It's like went back again and then again. It's the same question from Dr. Arwini, Andre. Arwini, what is the consideration for marsupialization and whether you prefer radical or conservative treatment? I think it's clear that you prefer conservative one, but it is any consideration for marsupialization, contraindication?
Yeah, I think in terms of consideration, I could say marsupialization is an easy procedure. You can do it with local anesthesia. So I think the most important thing, it's first, you need to keep the entrance open. So we change the dressing daily, not only for remove like from bacteria, because it becomes a cavity and there are a lot of bacteria. If you don't change this, probably gonna have infection there. So that's we usually replace the gauze. First, the gauze, wash it with like a saline solution to remove bacteria, and place gauze again with some antiseptic solution. And if you need to follow up and taking like routine X-rays. Maybe because sometimes you have like tumors that are multicystic, so they create like it's not just a single lesion that combines everything. They can create compartments. And if it's not responding all of them, probably because it's a closed one, you should go there and explore this area and communicate all of them. It's like a same principle that you use like in odontogenic infections, for instance. If you have like 3, 4 like facial spaces involved, you need to explore all of them. If you just give incision, start to drain some holes there, and you don't explore all of them, the patient will keep maintain the infection. It's the same principle. You need to explore all the areas. If you do that, probably gonna have a good result.
Okay, thank you, Dr. Andre. And the last two, before we close this session, if two people with the same treatment and condition, food, nutrition, they all the same base, will the duration of ameloblastoma recurrency is also the same? Mike, the question is what makes the contribution factor for recurrency in ameloblastoma mostly?
The growth factor, the contribution of growth factor for growth of ameloblastoma.
What is the factor that might contribute to the recurrency of the ameloblastoma?
The tendency, the probability is the recurrence occur in both patients. If young patients you have recurrence in the other, no, you need to check your diagnostic.
Okay.
For confirm the ameloblastoma. The kind of ameloblastoma is important too.
Yeah. Okay.
But the tendency of ameloblastoma is make a recurrence.
Okay. It's tend to have
it's really difficult. In my opinion, it's difficult to know why one patient, the same surgeon, you're gonna have result A and another B. We have like we have a difference, as John said. It can be due to the characteristic of this tumor. Not all ameloblastoma is equal.
Yeah.
Difference. So one can be, even from the same histological type, they can have difference. They can be more aggressive than the other.
Okay. So no exact indication.
When João is studying these cases, when you can see the expression of these proteins, they vary between different cases of ameloblastoma.
Yeah.
That's why look at any graph, you can see that these arrow bars. But in general, when we think about when we do this kind of study, in general, in all ameloblastoma, for instance, they express more proteins than a non-aggressive tumor.
Yeah.
But there are variations between the ameloblastomas.
Yeah.
Maybe it's one factor. We cannot know when we are treating. But and also it can be like the technique. I don't wake up in the same day with the same skills. Some
of course.
everything that I do looks great.
Yeah.
Another day, I'm doing the same. I have the same skills and the same knowledge. Something I do that nothing works.
Yeah. I understand.
But yeah, it's difficult to know.
Yeah. No exact indicator for what makes the recurrency in ameloblastoma. Okay, the last question. Have you had a reconstruction plate which combines a crista iliaca bone graft or rib bone graft?
Yeah, I have tried like not many times, but I would say 5, 6. At the first glance, they look great. You do this and say, "Oh, I did a great job." I removed the tumor, I put the plate there, I stabilized, so the reconstruction plate keeps like the mandible stable, and I put the bone. And the first week everything looks fine. The wound looks healing, and then time passes by. And the patient comes with swelling, and then drainage of pus. And then what happens is infection. It's not because it was probably due because these cells, they don't have enough blood supply. All these grafts, they require like all these cells, they will need to remember first, like we are like, interrupting all the local blood flow, and you put a bone that cells deep inside the bone that they need like oxygen, nutrients, and those oxygen nutrients, they don't reach them. What happens with these cells? Necrosis. And due to this necrosis comes then infection, resorption, and I wouldn't say all the bone, but most of the bone is lost. Not initially because due this lack of blood flow, and after due to infection. The problem, so you create like a huge morbidity where wherever you harvest the donor site, put the bone there, and most of this bone is lost. And sometimes because you need to do, because of the infection, while you still have like a necrotic bone there, infection persists. So you need to help aerate the area to clean this up. And at this time, you probably remove most of this bone was like grafted there. So experience, have tried like using like a block of bones. Like I've used like iliac bone, I think the leg as well. I forgot the name now. The bone. And I have used a cancellous bone, many techniques. Even tried hyperbaric oxygen therapy, and none of them worked in my hands. Mm. So far, the only thing that it has helped in these patients is microvascular surgery. Mm. Unless you have a very small defect. If you have just a small defect, I would say 5 centimeters or less, maybe I could try free bone graft. Otherwise, I wouldn't try this.
Okay, excellent. Excellent. Thank you so much, Andre, and Prof. Joao for a very interesting, brilliant presentation tonight for the first session. So for taking home messages, I repeat again that the ameloblastoma has an important factor for the invasiveness, like the metallomatrix protein, the growth factor, as well as the invadopodia, which a key protein of TKS5, the MTI, and TKS4. And for the treatment of ameloblastoma, Andre here present alternative treatment by marsupializations. I don't know whether it is published already, Andre, but it's a good idea and a good alternative to treat the ameloblastoma, as well as a good philosophy to treat patient, more centered patient rather than the tumor-based treatment. It's a good philosophy for us as a doctor. Thank you so much for a nice presentation again. And many of our participants say it's a excellent presentation from both of you speakers. Thank you so much. Okay, I'll leave this Zoom to Dr. Israyani as our MC to go to the next session.
Okay, thank you, Dr. Ani. Thank you, Prof. Joao and Dr. Andre. It was a great discussion about ameloblastoma in our session in this event. Okay, Ladies and gentlemen, distinguished participants, for time efficiency, we are now going to the second session. And the session will be led by our second moderator, Dr. Gigi Yosi Yohanita Aryastina, SPBM. Let me introducing her. She was born in Ujung Pandang, south of Sulawesi, Indonesia, in April 6 in 1984. Graduate her dentist degree from Hasanuddin University, specialist of oral and maxillofacial surgery from Pajajaran University. And she is currently a lecturing staff of oral and maxillofacial surgery department in the Faculty of Dentistry, Hasanuddin University. Okay, Dr. Yosi, this is your time, and please, the floor is yours.
Okay, thank you
Thank
very
you very
much.
much.
Okay, now I'm in the line again. So, John, would you like to say goodbye?
Thank you very much. Thank you very much for that.
Thank you, Prof. Joe.
Before actually we have we need to give Prof. Joy the certificate, but I think Andre will represent you if you don't mind later on with our dean a certificate award for this presentation.
Yeah.
Is that okay?
I can represent him.
Okay. Thank you so much, Prof. Joe, for a nice presentation.
And the certificate will be delivering by our dean, maybe. Please, Dr. Slim, for Prof. Joel.
Thank you very much, Professor Joel. This is the certificate. We will be sending you by email to you, and I hope next time you can give us lecture again, but not in virtual. We hope we can invite you come to Indonesia
in real life.
Thank you.
Thank you. Thank you very much, Professor Joel.
Thank you. Thank you.
Okay, Dr. Yosi, the floor is yours.
Yeah, thank you very much, Dr. Isa. Good evening, ladies and gentlemen, and all participants that already joined us tonight. I do believe, as I also feel the same way, that the previous session discussion was very interesting, and it feels like a little bit difficult to change the topic. But actually, the following topics are no less interesting, and it is regarding to the optimization of orthodontic operation result by using the three-dimensional virtual planning. And this will be delivered by Dr. Andre Luis Ribeiro, DDS, MSc, PhD. I won't read about your curriculum vitae because it's been read by Dr. Ernie. And I personally really looking forward to discussing about this one topic, because the 3D virtual planning, is it really could give a more precise treatment plan, because as we know that the orthodontic surgery plan is specified in millimeters, and is it could make the surgical guiding easier and shorten probably the durations of the surgery as well. Kind of curious, so distinguished guests or participants, please welcome our speaker, Dr. Andre.
Hi, thank you very much again. I'm going to start to share my screen. Okay, thank you again. Thank you for continuing watching us. I know that's very late for you. And yeah, my next topic is orthogonality surgery. And I'm going to talk a little bit about 3D virtual planning. Oops. Just a second. Yeah, just to those that are not familiar with, orthogonality surgery is also called like a jaw correction surgery. It's when we do osteotomies and in the jaws. Usually you can do it in the maxilla, mandible, and chin to correct like facial deformities. So basically we created these cuts, and then we cause a fracture in these bones, and after that we can move to any place that we we desire, like we want. And yes, there are limitations on this movement, but basically we can correct like bones that are not in place, or at least are not in good place with this type of procedure. All right. So when I start to talk about 3D plan, it's very important to talk about this digital revolution that we are seeing now. And it's happening in all the areas. You can see like machines doing like even works that are more precise and than humans. Digital things reach like the health size, and I think the best like dentistry was taken by this digital revolution in a very strong way. We are really changing the way that we perform dentistry. I think I finished my undergrad in 2002, and at this time everything was made by hands, and now we can do a lot of things using computers. And by talking this, I'm going to talk about my experiences in this digital world. So basically before 2013, I was like in my career, was teaching, was working in public services, and work as well a lot of time in A&E, accident and emergency. And I had a few contact with any digital tool and treated data. Basically at this time, I had like, I was using in some hospitals, electronic medical records. We could see some CT scans and see the screens, creating like a 3D view of like some structures. And basically was that. We are not like performing like 3D plans or creating like 3D objects from the digital world. It could help us to make like a kind of diagnosis, but it was stopping at this time, at least in my experience. Then I told you before in the previous presentation that for 4 years I moved to England for the PhD, and there I worked with basic research. So when I came back 2018, I was making a change in my career. So at this time I decided to focus a little bit more in my private practice. That was something that I basically didn't have opportunity to do before. And it was when I was introduced to this world. So when we talk about in the 3D virtual planning orthogonality surgery was the initial thing that was my introduction to this world. So before we had all these, we had to do all these steps here in orthogonality planning and surgery to end up with our splints and performing our surgery. For me, it was time consuming. Since I finished the graduation, I only worked with surgery, and I don't have main ability with prosthesis, so working with plasters and models was also, it consumed a little bit of time, was messy. Whenever I had to do like a model surgery, I was creating a lot of dirt, was powders spreading all the room. So for me, like it's a bit messy. So we need specific equipment. And also after you have finishing the model surgery, it was very difficult. If you didn't like something, basically you had to start again. And that was difficult to change a little bit to improve your treatment. And yeah, with like virtual planning, it became easier. We can try, we can test many things until we find the ideal treatment for the patient. So in traditional planning, we had the same, it didn't change. The facial analysis is still the same. You look at the patient, we put this patient in natural head position. We analyze, measure, take pictures. So we analyze everything that we can from this patient to help our diagnosis. So, and then we do the model surgery. So it will have to take, like, using the face bow, using the articulator, cutting, measure and creating the surgical guide using resins and in our hands. It was really time consuming, but if you do it right, you can reach a very good result and also predictable result. So it's not, what we need to understand is 3D virtual surgery, it helps us in diagnosis and planning, but it's not like we can still do very good orthogonality surgery use the traditional one. And because I don't know how things are in Indonesia, but in Brazil, the use of 3D surgery, created what is called translation. It's like a virtual surgery offices. So basically, you can change. Okay, you can send all the patient data, and they do the planning for you. And before, we had just like a few surgeons working with orthogonality surgeon, and because the osteotomy is simple, but all this procedure to planning and performing the model surgery was difficult to understand. And now people are sending to planning centers. Yes, this is the right one, planning centers, and everyone's doing surgery. But none of them have experience, and a few of them don't have experience. It becomes easier, and this is a dual side. I think to perform a very good surgery, you need to have like a surgeon that dominate all the steps of this procedure. So when you talk about, before we had this, like we had to create the physical model of patient, put in the articulator. Now everything became digital. So what we need, what's the workflow for like a 3D virtual planning? We're gonna take the data acquisition. So we need a CT scan and a surface scan. So, and the clinical data is the same. I use the same form that I used before. I still keep collecting clinical data in the same way. Okay, so after that, the CT scan, it can be or like a traditional CT scan or CBCT, doesn't matter. Surface scans, I usually use scanners, like it can be, I use an intraoral scanner. And then you take this data into a specific software. This is the most common software that we use in Brazil. I use the NemoFab, which is from Nemotech. It was developed by Professor Bill Arnett. Then you put this information together, and then you start to manipulate the data. So some steps are really, really important. Orientation, pace, put the CT scan in a position that translates the position the patient is in his real life. What it means, we need to put the patient in natural head position, and it is a fundamental step to get a good result, because if you don't place the patient in a good position, problem your surgical plan is not like it's gonna be like the best one. You're gonna be like in that, because patients with facial deformity, they usually take like different position in their heads, and the CT scan is taken with the patient laid over a table, and then it comes in a position that's not the one that patient assumes in real life. So this is a step, a really important step. It's difficult, and then you can do the osteotomies. You can plan your surgical movements. You can see how this patient, what is the soft tissue changes, and then you create your surgical splint. With this, I would say you are ready to go to surgery. Okay, so my facial analysis is still the same. I use this form so where I collect all the data, my clinical data, and then I took pictures. So I really like the pictures because I can compare my clinical. Sometimes we can fail in our analysis. I can say, oh, I'm measuring here. I can see there is a cant. There is a difference in the position of the maxilla. One side is 1 millimeter higher than the other, but I'm using my eyes, so there are like a space for errors. And I can use these pictures. You can see here, I use this mark that you can see in the face of this patient. With this one, I can calibrate the image, so I can have like a proper measure. You can do like marks, you can put 2 marks on the forehead. Let's say that you know the difference. Let's say you put 2 dots with 2 centimeters far from the other, and you take the picture, taking the software, and you tell the software that the distance between these 2 dots is 2 centimeters. So after doing that, you calibrate the image and you can take measures for whatever you want in this patient. Okay, and now I haven't used it yet. This is me. I only took this, but we also have like a surface scan. It also helps a lot because we're talking about like a 3D environment. When you take the CT scan, you're gonna be a 3D model, and you can superimpose these 2 structures, the 3D model with a face scan, and it's gonna help you to plan your treatment. I haven't tried this yet in orthogonality surgery, but probably soon I'm gonna do this. Another important step for me, I have discussed with some friends, and they have found some problems during surgery, especially because I don't know about how it is in Indonesia, but in Brazil, we don't have the CT scanner in our offices. It is very common in US, but here we need to send to a diagnostic center, an image center. So the patient go there, take the CT scan, and receive the results. The problem is, usually when you send these patients, the imaging centers, to avoid like intercuspation, to see all the teeth, they ask the patient to bite into the mandible, like this. But when you do this, you put the mandible forward, you change the position of the condyle. So the condyle assumes usually an anterior position, and you're gonna plan and you're gonna do all the surgical movements with this condyle out the position. And I have had a problem with this. I had friends that face the same problem, because when you do the planning, it seems that you're going to get, okay, I'm going to advance the mandible, let's say 5 centimeters forward. And then when you go to the surgery and the condyle returns to the natural position, they get sit on the fossa. If you do this 5 centimeters, it means that the condyle was backwards, so the mandible moved backwards, and to advance 5 centimeters, it's going to be not what you planned. It's going to be also your mandible would end up backwards. So I don't know if I'm being clear, but if when you take the CT scan, the condyle is out of the fossa, it's going to change whatever you're going to find during the surgery. So I usually take a bite registration. I put the patient in the way that I want. He want to take the CT scan. So he go to the imaging center, put this bite registration that I know I created, and he takes the CT scan using this device. It's a wax made, and it's not it's a hard wax that is we need to manipulate these with like warm water, so it don't like causing deformation or changes quickly, very easy. So it is a reliable way. Okay, then you get your CT scans, your surface scans, and you need to measure. Then because the surface scan has like more like precise details of the tooth surface, and you need to measure these models. Nowadays, the software is becoming, it was really hard before, but now with the updates, it's becoming quite easier. So basically, you merge this surface model with the CT scan, and then the CT scan, we're going to take the place of the tooth that were before in the tomography. All right. Another important tools that this 3D virtual plan helped us was like airway analysis. Before we had like a cephalometric X-ray that we could see only like in 2 dimensions. Now we can analyze the airways in different in different positions, and it completes probably all the goals that are preconized. For instance, for Professor Bill Arnott, he has this FAB concept that is facial analysis and improving the facial appearance of patient, the airways. So we cannot like imagine like a patient that you have like a good mandibular function or a good like a jaw and stable jaw position if this patient has like a breathing problems. So when we think in modern orthogonality surgery, we need to improve the facial aesthetics, the bite, and also the airways. If you don't do that, probably it can be a cause of like further relapse. So this 3D planning also helped the eyes to better analyze the airways. And so we can take more precise measures So we are talking about we can analyze like measure patients in terms of like 1/100th of like centimeters or millimeters. So we can measure this patient in a very precise way. And then you can correct any kind of facial deformity with pressure and with precise measures. And I usually, when I go to surgery, I took all this information with me, which helps during the operating room, inside the operating room. I know how many I put all the information, how much I'm gonna move. I have an idea how my bone contact will be after osteotomies, and we can plan and align all the movement, all the osteotomy that we're gonna do in any position that you want. You can see the patient in any position that you want. I think it's the main thing that help us to do a better planning. Before we had like a lateral cephalometric, and we usually do everything based on this analysis and the models. Now I can plan any kind of movement, can see what kind of interference gonna have, what type of bone contact I'm gonna have, and planning all the movement according to it. And to show how it can help us, I'm gonna show you this case. So this lady came to me. It was sent by her orthodontics, and said, "Oh, I don't like my smile, and it appears a lot of like of my gun, even when she's smiling, and even with like without smiling, she couldn't close her lips, and yeah, she had like a huge asymmetry in her face." Then I analyzed, I took her models, and okay, the occlusion is good. If the occlusion is good, it was good, it was stable. Any kind of deformity here I can correct during the surgery. And I started my planning. That was the patient. You can see how asymmetric she was. But perioperative, she had, I would say, it's not the best one, but sometimes it is difficult. The communication with orthodontists, I don't know how about it is in Indonesia, but sometimes, especially preparing patients for orthogonality surgery, it's not very easy. Sometimes, as a surgeon, I need to operate cases that are not prepared the way I wish. And even if with communication, sometimes you don't get what like the ideal orthodontic treatment pre-surgery, before surgery. So I took this patient and said, okay, let's analyze. Here's her model. And yeah, if you look, I'd say, okay, these models are okay, a good occlusion, a stable occlusion. It doesn't seem, it's not like, probably many of you can see that's not the ideal, but tooth are not that unlevel. So whatever deformity the patient shows, I can correct during surgery. And I started my plan. And after creating the osteotomies and trying to put the mandible in the position, the teeth in occlusion, that's what happened after my plan. So what I got, by placing these teeth in all the teeth in occlusion, the mandible, I displaced this mandible, and it became very asymmetric. I start to think about, oh, sorry, what is going on? If the occlusion okay, I'm gonna come back here and I'm gonna show I don't have like a deformity on the base of the mandible. The patient was that asymmetric. The maxilla was asymmetric, the mandible was, but the base of the mandible was still okay. And if I follow my plan, correcting both bones and place them in occlusion, I would end up with this mandible here, completely asymmetric. Movements that I had a lot of bone interference. Look how this movie, how the bone would end up after surgery. And then I realized there is something wrong here. Probably if I was working with traditional, like orthodontic surgery plan, I would place my teeth in the position that I want. I would put them in occlusion. I would say the occlusion would be stable, as we saw in the plaster model, in the 3D model. And I would take this to surgery. And during the surgery, I was probably try to put the mandible in this position. I would get a lot of interference. I probably would like, or I wouldn't fixing the bones here, or I would display the condyle out of the fossula. And when this patient wake up from anesthesia and recovers the muscle function, it's gonna be like a completely asymmetric. So I changed my plan. Unfortunately, I usually plan this case because to avoid, I took all the scannings, the CT scanning, the surface scanning. Just a few days before surgery, everything was red, the patient was red, and I had this dilemma: what I'm gonna do? If I leave this patient in occlusion, I would cause like a huge asymmetry mandible. So I changed it a little bit. Then I analyzed, I realized that the patient has, because of the orthodontic treatment, the mandible was like the tooth was misplaced, and what I did, I couldn't cancel the surgery and put the patient back. So I took the decision to perform and place the maxilla in the right position, and I left a distance. I left all the right hand side of the mandible without tooth contact. When you look to the planning, you can see here probably a few millimeters far from other. For me, okay, it was difficult, really, really difficult challenge. And I decided to keep on. And yeah, so I placed the maxilla in position. I put some anchorage orthodontic screws here to keep the maxilla position, and I discussed with the orthodontic, and I told him, okay, we're gonna close this occlusion after surgery. It's not the ideal, but this is my for those who knows like orthodontic surgery, we usually have a thicker splint, which is the intermediate splint, and a thinner one, and sometimes if the occlusion is stapled or even using the intermediate or the final splint. But here you can see my intermediate splint was thin, and the final splint was this huge piece here, because I had to leave the teeth out of occlusion. And here's the result. Okay, so I'm saying it's not like the ideal. The ideal is always we start with like, we prepare the surgery with a good and stable occlusion. But by performing this adjustment, I was able to place the maxilla in right position and maintaining the mandible in a symmetric way. And the dental malocclusion was corrected after surgery. Okay, so I think the main purpose of this talk here is just show you that without like if I didn't have this 3D environment to analyze the bone and the bone movement, I would probably end with the first plane in traditional surgery. And I would have two problems. One, during the surgery, I would probably, I wouldn't get the mandible bed position. If I was able to do it, I probably would end up with facial asymmetry. And another important thing as well, that these softwares and this 3D planning helps us is improving ourselves. So now it is easier to compare results. On the left-hand side, we can have like a pre-treatment. This is my treatment plan, and this is the final result on the right-hand side. So my final result is very similar to wherever I planned, which makes this virtual planning tell me that it is a reliable source, a reliable tool to plan this surgery. So when we compare 3D virtual planning with like traditional one, I can tell you that I can see some advantages in terms of accuracy, precision. For me, it's quicker, so I can plan. If I have all the data, I can plan a case in 4 hours, then have like more 2 or 3 hours of like 3D printing. I say here that's cheaper, we can question it, but the problem of 3D planning is the price of the acquisition of software is very high. But once you have it, and as much as you use it, it becomes cheaper because you don't need to like plaster, you don't need to you spend a lot of time, yeah, and this time is also has its cost. I like to say that it has more flexibility because I can try many different treatment plans to achieve the ideal one. It's a better tool for proper diagnosis, evaluation of results. You can also get like 3D printing and pre-bending the plates if you want, and also facilitate sharing. For instance, if I have difficulty to plan a case, if we both have the same software, I can send the case for one of you in Indonesia, we can share our opinions, and it has helped us as well to discuss with colleagues and in order to get the best results. In terms of advantages, I can say the initial cost, so, okay, it's quite expensive, and the learning curve is also a little bit hard. And for instance, I think the first case I took 1 or 2 days to understand all the tools, and many tools I didn't know how they work. So it's a little painful, this curve. It bugged. Okay, as all computers, it's very common. I can't remember if I had a case that I could plan from the beginning to the end without like the software stopped working, and we need to save every single step, otherwise we're going to lose all our work. It's very common, and not only for orthogonality. I'm also working with now other softwares for like planning dental implanting, guided surgery, and all of them, they have this bug. And another thing that I put as a disadvantage, it's outsourcing. So there are a lot of many surgical plans, and surgeons, they are transferring their responsibility to plan the case to the center. They give the center basic information, and a technician does all the planning. And the surgeon just check if it's okay. But I think it's not the best way. I know maybe experienced surgeons, they can do it very easy, but especially for younger surgeons, sometimes they don't have this experience to understand that there's something that's not good, and they receive this case already planned, and they will end up with a limited result. So when we talk about like virtual planning, there is a lot of things like that. There's a lot of development technology. So orthogonality surgery started with freehand surgery. So in the early, then we start to plan surgery with like this traditional way like doing model surgery and creating handmade splints. Now, most surgeons are using like CAD/CAM splints using this 3D environment. We also have something that is helping that when we creating these cutting guides and positioning guides. I'm trying. You can see here I'm using my software. I haven't like I couldn't like create this guide, but I'm adapting other softwares to creating some guides that can help me to place the bones in the right position. Especially, it's very, very useful for the team. There are like the 3 patient-specific plates. It's another thing that helps surgeons and surgical navigation. I can say like technology is good, but sometimes it's too expensive. Like these patient-specific plates that you go there, do your osteotomy, planned position. The plate is created for this patient, which takes the bone the right position that you position it during your surgical plan. But the cost, this is too high. At least it's not my reality. I'm still here using like CAD/CAM splints and creating my primitive positional and cut guides. And I think, and I have discussed a bit with the other colleagues, and we have some like these, many of them, there are some criticism to these like patient-specific plates. They are usually very high or very big, and you need to have like huge incisions, and it makes the post-operative period a little bit like more like difficult for the patient. And in Brazil, we have like some very good skilled like orthogonality surgeons. There is a surgeon that he developed this concept of, his name is Jonathan Klaus, and the minimally invasive orthogonality surgery. So he's performing very, very small incisions using just like a few small plates for fixation the mandible, or the mandible and the maxilla. Has changed a little bit the osteotomies to perform this, so he can do like maxillary left form osteotomy using 2-3 centimeters incision in each side of the maxilla. Very, very small incisions in the mandible, and he's getting very good results. And before, we had a problem using using traditional approach, even like using the normal techniques. We had problem, the patient stays a little bit without feeling, with the face numb, because of the trauma of the nerves, so the patient gets paresthesia. And he's now has to deal with like a pain of these patients. He says that, okay, now because I do very minimally invasive surgery. I cause minimal trauma to the nerves, and the patient recovers sensitivity very quick. And there is another surgeons in Brazil, they are doing this complete reverse planning. So basically, they start with the digital smile design. So they design the smile. All the orthodontics and surgery are planned not based on the final position, the final way that they design the smile of the patient. Before we had a orthodontic treatment and you plan the surgery, placing the bone and teeth in the best position that we want based on facial analysis. Now they have this concept, it's not enough anymore. They are designing the new smile, and the plan the orthogonality surgery should end up in a position that is is in a position to design the smile the way that they planned before. It's a complete reverse planning. Okay, so finishing this presentation, there is my taking home message. So the 3D virtual plan is a reliable and accurate technique for planning orthogonality surgery that helps surgeons to have a better diagnosis and treatment plan. So 3D virtual planning helps good surgeons optimizing their results, but don't make better surgeons become good surgeons. That means it's not because you do 3D planning and go to the surgery with your 3D printed splints. It doesn't mean that you're gonna get good results if you don't know how to plan your case. So you need to have a good facial analysis, a good plan to achieve a good result. And technology is good, but expensive. And it should never surpass good and care professionals. So even those surgeons that, if they are really, really dedicated to their patients, they are planning their case with accuracy, they can achieve very, very good results without any of this technology. It's a tool that gives us very, very important ways to analyze and planning. But the best thing is still a good analysis and look to the patient and dedicate your time to analyze them in the best way possible. So I hope you can get results like this. This is a patient that she had a very good and stable occlusion. It's a colleague, it's a dentist as well. And she decided to do the surgery because she had obstructive sleep apnea. And and she, before and after surgery, we were able to improve her quality of life. So she stopped, she reduced a lot the apnea. She's feeling really, really well, and we improved the facial appearance as well. Another patient, this one is a doctor, and her main complaint was this gun smile, and she a few years after surgery, and we got some patients that we are able to plan and offer them these type of results that we always look when performing orthogonality surgery. Thank you very much to everyone. Thank you, Hermes, again for this kind invitation, for friendship. Thank the university for inviting me and Joan. I think Joan got happy with this, all your kind message, and he's still here to see the end of this session.
Yeah,
and yeah, thank you very much.
Thank you very much, Doctor. It was very interesting presentation. Actually, at the some of your first slide of presentation, I was smiling because I imagined I was doing all the things the same way that you mentioned in planning the surgery by using a conventional planning. So, I mean, it would be great if we able to plan digitally so that we can eliminate all the technical difficulties when using the conventional planning. And I also realized one thing that the take-home messages that you said, this software won't make a bad surgeon become a good surgeon, because you still have to have a good plan of surgery. And also there's a lot of many considerations. And I would like to, oh, we have a question. This is from Dr. Asih Widyastuti. How if the digital workflow is applied in ortho treatment without surgery? How shall we do? Because I'm a beginner and interested to make progress. Thank you.
Yeah, we can do a lot in orthodontic treatment as well. All this, like one important tool that we have in orthogonality surgery is this possibility to show the patient before any treatment that how he gonna end up after surgery. So we can simulate all the changes in her face, in her bite, in their bite, before any treatment. So we can we can go and make the movements as when you are planning orthogonality surgery. You place the bone in the position that we want, and you're gonna see the facial change, the bite change, everything. All the same tools are available for orthodontic treatment. For instance, I use this software from Nemofab, from Nemosef. They have the Nemo scan, so you can simulate all the position, the dent of the teeth. You can change the inclination, moving the teeth, and see all the how it's gonna reflect on the face of the patient. And another, so you based on this, you can create, for instance, the ideal position of the brackets, the braces, and you can have a printed guide to place the braces in the right position. And I don't know if you probably heard something about the aligners, the clear aligners. And while we are doing like traditional orthodontic using braces, you place the braces in some position, and then go to the wires. The wires is gonna move the tooth. The wires is gonna, if you place let's say you place the braces in the position of each tooth that's not aligned. When you put the wires goes there, like makes like they're gonna be straight, and you put the wires, they're gonna be, the wires that has like this memory, they're gonna start to stay straight. It means that all the movement is based on how you position the bracket, the braces in individual tooth. But with aligners, you take the patient, you plan your final occlusion, so you know you design in a 3D environment how you want to end up with each individual tooth, and then you go from the ideal occlusion all the steps backwards, and it creates this, and the software will create aligners that you're gonna move every single teeth in the way that you plan it. So basically, you know, while you are doing traditional orthodontic treatment, you do your analysis, and you're gonna keep going forward until you achieve the results. With like a 3D environment, you design whenever you get in the end, and comes backward. So there are a lot of possibilities, and you can, whenever, if you need to use any type of orthodontic anchorage like screws or plates, you can design guide for placing them in position. There are a lot of tools that can be used in orthodontics.
Okay, thank you very much, Doctor. So by using the 3D planning for the ortho treatment, we can plan and simulate a virtual treatment before even doing it. I think that's what you mean, kind of that.
Yeah, I can, for instance, because I can get a patient that he or her is thinking doing surgery. I can simulate some orthodontic movements, and it's going to generate some facial changes. Then I can simulate my orthogonality surgery and pick the patient before any type of treatment, simulate the dental and bone changes, and show them how they're gonna finish the results. So there are a lot of possibilities, and it helps us. It's not like it also helps us as a surgeon to show the patient why we are proposing them this type of surgery. It's not like orthodontic surgery. It's not like it's a big surgery. I mean, it's not easy. The postoperative period is hard. The patient has difficulty to chew. The face is swollen after surgery. There is paresthesia that can take months. So sometimes the patient, I don't like my bite. And then you say, oh, you should do this surgery. You're going to take 1.5, 2 years of treatment. Nobody wants it unless you show them why you are suggesting this treatment. And this software is a very, very nice tool to show to show what you're planning to this patient.
Thank you very much for the explanation, Doctor. Is there any potential errors according to your experience by using this 3D virtual planning?
Yes, most errors are human errors. If you don't know how to plan traditional, you don't know how to plan virtually. And every method has its particular error. For instance, when I'm taking the dental impression, if I commit some error during the dental impression or during the creating the model or taking the face error, if I put the articulate in a different position, I have I'm gonna have problems during my surgery. So in 3D virtual planning, I don't have this, but I have another, or I have others errors. For instance, I told you about the position of the condyle when you take the CT scan. So it can be a problem. If you don't place the patient in the right orientation, you're gonna end up, it means if I look into me, if I put the patient this in during my planning, and I level the maxilla, because the head is not in the right position, the maxilla in the software, you're gonna be in this position. Then if I correct my face, my maxilla is gonna be bended. So this is an important step. So you need to, there is these tricky parts when doing 3D virtual planning, but we're gonna tell you, and I think the most important thing is it's reliable. Whatever you do there, if you do right, you're gonna get exactly the same result. And the studies comparing traditional versus 3D planning show that there are more accuracy using 3D plan. Errors, yes, there are many that can occur, but it's basically man-made errors. So that's why I really think that we surgeons, we need to do our plan. We need to look at our placing, put them in the ideal orientation, not transfer this service to a technician. There are parts that, yes, can be made by a technician, but some steps need to be done by the surgeon.
Thank you very much for the explanation. It was a very clear picture about how this 3D virtual planning is supposed to be used. And if there's no other question from the participant, I might can give a little conclusions about the topic. So this 3D virtual planning is can be used for optimizing result in orthodontic surgery, of course, because this allows the surgeon to anticipate, to plan, to simulate a virtual surgical procedure before undertaking real surgery, and even share the virtual research beforehand with the patient, as you said before, to increase their confidence and also satisfaction, and to be more sure if they want to take the surgery, the orthodontic surgery for themselves. So in this way, maybe we can unforeseen a complication in addition to reducing surgery time and also the post-operative trauma for the patient. I think that's all. Once again, thank you very much, Dr. Andre, for your great sharing of knowledge and also experience in using the 3D virtual planning for optimizing the result in orthogonality surgery. Thank you very much. And I'm going to return the lead of the forum to the Master of Ceremony, Dr. Isra, please.
Thank you, Dr. Yossi, and thank you again, Dr. Andre, for the great presentation and great discussion about this topic in the second session. Ladies and gentlemen and distinguished participants, the next session is certificate delivering for Dr. Andre. That will be given by the Dean, Dr. Ruslin, please.
Dr. Andre, thank you very much for your good lecture. And this is your certificate we send by email to you. We are really honored you have time to give a lecture, excellent lecture. Thank you very much.
I appreciate it. Thank you very much, all of you. We are a little bit far, but we can give like virtual hugs. Thank you very much. And we appreciate that. It's, yeah, we had like this COVID, like a pandemic that reached the entire world. And I think I had time to stay at home. And besides all all people that got sick and unfortunately some of them passed away, but I think it opened a new window for us as professionals because it became more like common. I think during this pandemic, I started to do this like a virtual conference and I could learn a lot.
Yeah.
And I think it opened a very important like a way to share knowledge. So we are like far away of each other and we can chat, we can talk, we can help each other. And yeah, it's a really a pleasure to be with you today. Thank you. I know that's very late for you. And thank you very much. And you can count with us to wherever you want.
Okay.
Thank you.
I was really visit Ernie and your university. I have seen beautiful beaches that you have in your country. They are amazing.
I will invite you someday, Andrew, Prof. Joao, when the condition getting better. Yeah, I'm waiting for you to come here.
Or maybe we could give a visit.
Yeah. When you get
whenever the pandemic is over.
Well. Andre, remember? You
What?
promised me when you wedding day, I have to go there. Remember?
Yeah,
I'm still waiting.
I'm still postponing it. I hope you have a long life so far.
I will be
Still
there.
enjoying the life.
Yeah.
Thank you so much. And it's nice slide, especially the last slide you have. It's the best picture you have. The
Yeah.
yeah. I think it was your last our last Christmas party.
Exactly. A few days before the party.
Yeah, I remember. It's nice. I really miss you guys, Prof. Joao. Thank you so
Miss
much.
you.
Yeah, it's true that the COVID things actually make us more related each other, more close each other rather than before. Because I know if this is not about the COVID, we can meet. Usually people don't accept it conference via online, but now we consider it as a more common way to do this webinar. And I'm happy that we have you here with us. Thank you so much.
Okay, thank you.
Professor Joe, Dr. Andre.
Okay, thank you, Prof. Gio and Dr. Annie. Now we are going to listen to the closing statement of this program that will be delivered by the Dean of Faculty of Dentistry, Hasanuddin University, Dr. Gigi Muhammad Ruslin, MKS, PhD, SPBM Consultant. Please, the time is yours.
Thank you very much, the Master of Ceremony, Dr. Isra. Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen, and our honorable guest speakers, Dr. Andre Luis Ribeiro and Professor Joa de Jesus Vena Venhero. It's an honor for me as the Dean of Faculty of Dentistry, Hasanuddin University, as the host of the third virtual international symposium series, the oral and maxillofacial update, with the theme odontogenic tumors and optimizing results in orthodontic surgery using 3D virtual planning, to present it a closing treatment. On behalf of the Virtual International Symposium Series Committee, I would like to express my gratitude to all of you who have spent your time and participating in this virtual event, which has enabled us to conduct a highly fruitful symposium. Some issues has been discussed in this symposium, such as the odontogenic tumor and 3D virtual planning in orthodontic surgery, that was delivered excellence by Professor Joao and Dr. Andre. Both topics are important as we can perform a better surgery planning and reach a better surgery outcome in our practice. Highly appreciation to our both speakers, Professor Joao and Dr. Andre, for sharing their great knowledge and experience to us tonight. For both of you, again, sincerely thankful. The last is my hope that this virtual symposium as experience of our commitment in strengthening the knowledge and skill of dentists and also specialists in dental, oral and maxillofacial field during pandemic session. I also thank to my college who is attend this symposium, and special to organization committee for their super job in making this meeting happen. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Roslin. And thank you again for Prof. Joao and Dr. Andre for the great presentation tonight in Indonesia. And ladies and gentlemen, distinguished participants, now we come to the end of this symposium. Allow me, Dr. Gigi Sayani, and all organizing committee to say thank you very much for your participating and attention in this Zoom meeting and our YouTube channel, and apologize if there is any mistaken in this event. And for your information, this virtual international symposium series will be continued next month with another topics. It's about current issue in dental public health. Hopefully, we will see you again in next month. And thank you very much for your kind attention. Assalamualaikum warahmatullahi wabarakatuh and good night. See you next time,
Thank
Dr.
you, Professor
Joao.
Joao.
See you.
Bye, Andre. Bye, Prof. Jao.
Thank you.
Bye. Bye.
Thank you so much.
Thank you all of you for the committee.
Thank you, Doc.
Terima kasih.